So my co-founder and I, we established Operation Asha, and we thought, let's take care of all these problems that people are facing. We have to ensure adherence. We have to see to it that they take their full treatment. They don't get drug-resistant TB. Treatment has to be made available at the doorsteps of the disadvantaged. In order to overcome the challenge of lack of adherence, the WHO and CDC together, they brought up the DOTS model. DOTS is an acronym for Directly Observed Therapy, short course. By direct observation, it means that the patients are not given the medicines to eat at home. The medicines are kept in these designated centers. Now, these centers could be the government hospitals, the public hospitals. They could be the primary healthcare clinics. They could be just any person who wants to be a partner of the government in order to do the delivery of the TB treatment. That is a DOTS center. So basically, DOTS is a very good concept because it means that the patients will be given medicine under observation, and that is assured. But the flip side of the coin is that patients might not really go to the DOTS center so often. And what do? I went to a very large public hospital before we established Operation Asha to see what was going on. There were thousands of patients. There was one huge hall. There were 2 or 3 people from the government staff trying very hard to attend to these people, so many patients, and really failing. And they would call out one name, and 3 people with the same name would come running forward. I went and spoke to the gentleman in charge, and I said, what do you do if a patient doesn't turn up? So he said, what can you do? What do you expect us to do? We are spending the whole day here. We don't have the time and the resources to go to patient's house and bring them back. So when do you take action? I asked. They said, well, the government audit is done after 2 or 3 months. Then we get to know who is missing. And is anything done after that to retrieve the patient? No, nothing is done. Firstly, we work as partners of the government. So we get free government medicines, we get free diagnostics, and we get the services of TB specialists in the government for free, which provides a great leverage. We also get a government grant for treating tuberculosis, which adds to our sustainability. The urban model is established where patients are densely packed in the slum areas. So what we've done there is that deep in the urban slums, in temples, in gurudwaras, in clinics of quacks, in homes of housewives, we've got these centers open, the DOT centers. The advantage of using the local infrastructure, the existing slum infrastructure, is that, number one, we don't have to hire premises. And the second most important thing is that these centers are there. They are open early morning and late night. I'll give you an example. In the Hindu temple, the first prayer is at 6:30 in the morning. So just think of little children going to school. They walk past the temple, they stop there to pray, and they take their medicine, and no one needs to know. Their privacy is maintained. Similarly, the last prayer is at 9:30. So factory workers working an evening shift, they can also get their medicine. The medicine is available for extended hours, and there at nodal points, imagine an entry point to the slum, and there is a DOT center. Operation Asha has hired a cadre of workers known as the TB treatment providers. Now, these providers belong to the communities they serve. They are from that particular slum because each slum has a different character. People speak a different language, eat different kinds of food, and you and I cannot go there and talk to them or sort of expect them to identify with us and to listen to us. But someone who belongs to that area, he or she is the best equipped to solve their problems, to persuade them to take TB medicine, and most importantly, to navigate the informal geography of that area. Because in the slums, there's no road number and house number, but so it has to be the local people doing the work. What we have got is local people hired as treatment providers. Now, these providers sit in the treatment centers, in the clinics of the community partners, and they help give the medicine to the patient. They also solve all the day-to-day problems of the patients. Before we start TB treatment, the provider has to visit the patient's family. 1 hour counseling session where the entire family is told about TB, how it is a contagious disease, how it can affect others, and how it can be prevented by taking basic precautions. It's important to inform the family members for 2 reasons. Number one, if we inform the family members and we persuade them that this TB patient needs care and will become an important member of the family sooner or later, then there is no stigma, there is no discrimination against the patient. And the other thing is that the family members will take the suitable precautions, like disposal of sputum, like opening the windows, because the sun and the wind are the best sterilizers in a poor country. All this is taken care of in the counseling. In the first counseling, the message is given. In fact, we just go after them hammer and tongs. You have to adhere to the medication, otherwise you'll get drug-resistant TB. And we take action on a single missed dose. We don't wait for months and months. If a patient does not come to the TB treatment center and doesn't take the medication, the provider has to go to the patient's house, repeat the education, retrieve the patient, bring him back into the system. That is the work of the provider. And by the way, he's getting a cash incentive to do all this. I realized that when there is so much data fudging everywhere, it can be there in my own program. Especially when you give incentives to people to detect patients, to ensure adherence, one wonders, is the work really being done or is it not being done? The technology device is very simple and low cost. It consists of off-the-shelf components, a simple phone and a fingerprint reader attached to it. The software has been developed, and each patient is enrolled by the fingerprint. Now, when the patients come to the DOTS center, they have to give the fingerprint. There is minimal text on the screen. The screen turns green and says so-and-so logged in. The patient takes the medicine and goes home.
मैम मैं उंगली के निशान देती हूँ और मैम मुझे दवाई देती है।
मतलब पूरा मैनुअली में क्या होता है, कई बार हमें क्या लगता है हम चले जाते हैं तो पता नहीं चल पाता कितने पेशेंट हमारे रह गए, थोड़ा सा दिक्कत होती है। तो इससे हमारा ये लगने से हमें ये पता लगता है, हमें मैसेज मिल जाता है हर जगह से, पेशेंट के पास भी इसका मैसेज आता है और हमारे पास भी मैसेज आता है कि आज के हमारे कितने पेशेंट रह गए। फिर हम उनको ट्रैक बड़ी ईजी तरीके से हम कर देते हैं। तो हमारा मैसेज आ जाता है, फिर हम उनके घर जाते हैं।
This system is connected to the electronic medical record system at the back end. In real time, we get to know which patient has not come because a text message is going to the program manager and the provider, maybe also to the patient if the patient agrees to such a message. Very often they don't because of the stigma. But we get to know, and the provider has to go to the patient's house, take the fingerprint in remote setting as proof of visit, and also by geomapping we know whether the provider has been there or not. And this prevents data fudging. It ensures the work has been done. And we are very sure that now we are not creating default and MDR TB in the world. Previously, when we were giving money to the providers, the thought was there in my mind that these providers are reporting that I've done default tracking, I've gone to the patient's house. Suppose he hasn't gone for months and months. Patients are suffering, we are creating MDR, we are not here to do more harm than good. So that is why technology is so important. Operation Asha is a unique organization when you consider its community outreach and the low cost. We believe in a measurable impact and we measure everything. The number of TB patients treated, the death rate, the default rate, the treatment success rate, the cost per patient. We made our first center in September 2006 and we haven't looked back since then. And now we are serving more than 7 million people in India and Cambodia, and our work has been replicated in 4 other countries by third parties. We've already treated more than 55,000 TB patients and more than 260 patients of MDR TB, also a few of extensive drug-resistant TB. We've kept our costs low by getting everything we can get free from the government, and number 2, by utilizing the existing community infrastructure deep in disadvantaged areas. So we do not hire premises, we do not pay someone to sit 6 a.m. to 10 p.m. and do the DOTS therapy for the people. It's some local priest or a local housewife who's doing it for us. Our centers are deep in the community, near the patients.